Hello and welcome to TEDMED's Great Challenges. Today we have a very, very important and interesting topic to discuss, and that's eliminating medical errors. My name is John Nosta. I'm Executive Vice President and Senior Strategist at Ogilvy Common Health Worldwide, and I'll be moderating the program today. The concept of great challenges out of TEDMED is to look at 20 of the most complex and complexing problems in healthcare and try to advance the dialogue. Our objective today is certainly not to solve these problems, but to look at them from a comprehensive perspective, bringing in a variety of stakeholders such as our clinical experts today, but also stakeholders from the online community, such as Twitter and Facebook, to broaden our understanding of these topics and simply advance the dialogue along. These sessions are part of the Great Challenges programs that are sponsored by the Robert Wood Johnson Foundation. We will be taking questions from viewers on our Google Hangout, on Facebook, and on Twitter. So if you're on Twitter, we're at TEDMED, and please hashtag your question with hashtag Great Challenges, there's an S at the end, and also on Facebook. We'll try to get to them if we can. We have a great panel of experts to help us discuss our topic today, and let me introduce them. Thomas Gallagher is Professor of Medicine, Bioethics, Humanities at the University of Washington School of Medicine. Paula Griswold is the Executive Director of the Massachusetts Coalition for the Prevention of Medical Errors. Karen Scott is the Vice President for Quality and Patient Safety at New York Presbyterian Hospital. And Michael Victoroff is Executive Vice President and Chief Medical Officer at Lynx Care. You can read more specific and advanced profiles of our panels on our website. So let's start our discussion with a simple yet startling fact. Every year, medical errors are estimated to be about 2.4 million in terms of patient involvement. That manifests in medical errors that link to or are associated with approximately 200,000 deaths. That's a tremendous number and a tremendous clinical concern. So we'd like to start our discussion today with some background about the clinical reality of this. What's the actual reality as a rank and file practicing physicians? So I turn that over to our panel. Doctors, is this a compelling concern, or is this a cost of doing business?
Well, I would say as a clinician, patient safety and the impact of these events on patients is a huge issue. The exact epidemiology I don't think is super well understood, but as a clinician, we know that these problems are much, much too common. We know what a terrible effect that they have on patients, and I think clinicians are starting to realize that even though historically they've been focused on things that they can do individually to make patient care safer, they're just starting to learn about what are the things we can do to work as teams and work with systems to improve care. And I think that's where enormous potential for improvement exists.
And if I could add, it's obviously, as Tom has said, there's a personal tragedy for the patients and families involved. It's also a particularly timely discussion because if we're concerned about the levels of federal spending and state spending and private spending on the cost of health insurance, it's clearly an additional tragedy to spend any of that 18% of GDP on care that's harming patients and then trying to help them recover from it.
And I think Tom used a good word when he said epidemiology, because that implies that there might be a scientific way to study errors and mistakes rather than simply to talk about them anecdotally. And I would say just on that topic, we tend to lump errors into a box, like we would say, oh, there's such a thing as infection, or there's tumors, or there's fractures. And that's very lovely, but we're never going to be able to address them unless we learn to understand them at a little more granular level and begin to parse them out in terms of which are preventable, which are unavoidable, which are minor, major, which are intercepted, which have terrible consequences. And I think there are a few people beginning to do that, but the discussion needs to go in the direction of let's understand these things as an epidemiology, rather than simply to say, well, all errors are bad, let's pretend we can have zero.
So Michael, let me interject right there. You raise an interesting concept. We need to fix what is fixable in the context of medical errors. Could you help us understand that a little bit in the sense of perhaps a clinical example?
Well, one very simple distinction we could make about errors is that there are certain errors that occur that have no consequence or create no harm. Some of them can be catastrophically bad errors, but if they're intercepted by the usual error prevention systems, or they're caught before they do harm, they're just misfires, and they can be instructive. We should study them. Oh yes, my goodness, I personally have made some catastrophic potential errors where a nurse tapped me on the shoulder and said, wait a minute, you don't mean to do that, do you? And we stop and we say, oh my God, no, thank you. You just saved a patient's life. Terrific. But I still get a point there for having made an error. On the other hand, there are trivial, minor things that we could see, like one little keystroke, one word mistaken in a transcription, one nurse who reads the wrong wristband on a patient, a terribly tiny thing in the scheme of the universe, but it can be fatal. So we have to learn to sever the seriousness of the error from the seriousness of the effect.
I think that's an interesting observation. So it's been 10 years since the To Err is Human IOM report, and I'm curious, simple question to the team: how are we doing? Are we, what's the state of medical errors since that landmark publication?
John, I think the good news is there's been a tremendous amount of progress. I think there's a whole different level of awareness among leadership in the healthcare community, the frontline staff, understanding patient safety, working on patient safety. And while tremendous strides have been made, at the same time, I think there's still a huge amount of improvement that's needed. We're still introducing more complexity in the way care is delivered that creates new potential for error. We'll probably have an opportunity in the coming hour to talk about technology, but there's more medications, there's more tools that are used, there's more organizations trying to work together. So that's the complexity that introduces more opportunity for error, and there's still a long ways to go.
So
I would say the biggest I would say the biggest thing that has happened since the year 2000, since I was counting and trying to record errors back in the 1990s, that was a very amusing time, because I could go to a medical society and I would ask them Wendy Levinson's question, Tom, a colleague, I think, of Wendy, and she wrote a paper back before the IOM report. She asked a bunch of doctors like I did, well, how many errors have you made? Like, what's your error rate? I still ask that of residents. And really, the year 2000 is a watershed, because before that date, you could be in a room of 100 doctors and listen to 5 minutes of silence. And they would look at their feet and each other and they'd say, I don't know, gee, really, an error? I'm not sure I ever heard of one. Errors, what are you talking about? But then after the Institute of Medicine sort of brought them out of the closet, now I can go to at least a room of residents. I don't know about the older docs so much, but the residents, I'll say, hey, let's throw a few errors on the table. Tell me something you did yesterday. Tell me an instructive thing you were standing next to or you caused that we all could learn from. And we would get a flood of discussion about errors where suddenly, the E word we're allowed to use now. And I give credit to the Institute of Medicine for having made that possible.
So let me chime in and understand that a little better, because I think this is an important construct. So what used to be the idea of not in my backyard, or I'm not the one making the errors, that's the other physician, is self-reporting more prevalent now, and how does the actual reporting nature of medical errors play into this stream?
Well, I work for a company that provides malpractice insurance, and one of the things that we did 30 years ago was something radical. We said we'd like the docs to report occurrences, but look, we have legal immunity. You can talk to us. It's secret. We're not going to tell on you. Plus, we're your defender. We still have a shame and blame culture in most of American medicine, and the consequences for self-reporting errors now are still potentially hazardous, and the mythology about reporting errors is you can get in big trouble if you open your mouth here. Better to be quiet. So we not only have the traditional impediment, which is I'm ashamed, I don't really want to talk about this except to real grown-ups. We have journalism, we have lawyers, we still have a very hostile external environment. And the only thing that's really changed in the last decade or so is there are a couple of better sanctuaries now where clinicians can actually come and confess and apologize and talk sometimes to patients in an environment where they know they're not going to get their license yanked in the first hour. But we still have a long way to go in terms of maturing the level of discussion about objectively discussing mistakes.
I think that fascinating words, when you think of the lexicon of clinical medicine, oftentimes words like apology or sanctuary tend to belong to a completely different organization, if you will. Is that emerging as relevant? Paula, are people more, clinicians and people involved in practice, more apt to have that sense of being apologetic or seek out that sanctuary environment?
I think there's been tremendous progress since the original Institute of Medicine report, but there's still a long way to go. I think that there's not necessarily the training and support that would benefit clinicians in all organizations about how to have that difficult conversation with a patient. So, as Michael had said, we're a great deal farther than we were 10 years ago, but the culture hasn't changed enough.
A question for you about the data from the IOM report. Those numbers that were cited, are the actual occurrence of errors increasing or decreasing? And perhaps, maybe, Michael, you can put that into some statistical perspective as the market grows or the complexity increases?
Yeah, that's easy. How many craters are on the dark side of the moon? We have no idea. How would you establish a trend for something that you couldn't even count a few years ago? No one knows what the baseline rate is. No one knows what the variances are. I don't know if Tom's medical school is better than my medical school. One thing I would love to do would be able to say, well, if you guys have a better way of not operating on the wrong patient or not giving the wrong medicine or not putting the wrong baby in a crib, I'd love to know how to do. Who's the best at that? Or who's the worst? Even that would be helpful. The CDC can tell me who's got influenza, but we can't tell who's making errors. And I think any attempt, I mean, the original Institute of Medicine number was a fantasy. And right now, we're still a long way. There are local institutions that can tell you what is going on within them. But since we don't have a uniform language to discuss and compare, I don't think any epidemiologist can truly say what's going on and is it getting better or worse.
Well, Michael is talking about an even more profound problem, which is, institutions generally don't do a great job of collaborating with one another when care has not gone well. So there are a variety of reasons for that. But as Michael was saying, there's an enormous amount we could learn from one another, but institutions usually keep these events within their own walls, and there's not nearly the shared learning that we really need to make meaningful and dramatic reductions in medical errors.
And
I'll give you one. Go on, Paula. Go ahead.
Sure.
Just to emphasize another part of what Michael was saying, I mean, I think there are certain kinds of errors that we are able to measure and that people have been working very hard to make improvements. But one of the core concepts in quality and safety improvement is you can't manage what you can't measure. And the problem is we don't have the totality of knowledge and the measures of all of the things where there's patient harm. So we don't have the totality of sense of are we improving overall and how much harm are we continuing to do in patient care.
So I'll give you one anecdote about this. We collaborate with data people who are sort of in the same business all over the country, and once in a while we share, as Tom says, much of this is very sensitive and cannot be shared, despite the Patient Safety Organization effort at ARC, which I consider to be mostly a failure. But sorry, guys, but we do internally talk under privilege to other organizations. I saw a report from Massachusetts a couple of years ago, and and they were looking at retained surgical foreign bodies, and over an 8-year period, the Mass General hospitals, they found 21 retained souvenirs inside of patients. Okay, that's interesting. I said, okay, let's look in Colorado where I work. I looked in our database and I asked, okay, retained foreign bodies, let's see, we got blah, 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 blah. I got 305. Okay, so now in our little tiny malpractice company, 1/10 the size of Crico, we had 305 retained objects. They had 21 in the same 8-year period. Now, I called up to the folks in Boston and I said, hey, you guys, we got 305. And they said, oh, well, you know, we're Harvard. Then I said, oh, well, we have a collecting system. So the issue really in this is we can't find the errors enough to know who even has reliable data. You know, if they really had 1/10 the number of events that we did, I should get on an airplane, go up there and learn how they did it. But in fact, they got on an airplane and came down to learn how we collected all that data.
So, Michael, is it that the MGH isn't looking? Is that your inference here?
Well, in this actual case, it turned out there was even a more subtle problem. They were looking, but their database reported them under the wrong label, and so they got the wrong total. And then when they went back and looked again, they were able to find hundreds of the same sort of thing I found. So this is it's an informatics problem. It's a labeling problem, a definition problem. You know, when I ask the residents, how many errors did you make last week, they say, well, what do you mean by error? And so we don't have a standard definition of what a foreign body is. You mean a sponge, or do you mean a splinter, or do you mean products of conception? We have a lot of sort of technical science work that we need to do in order to actually have this discussion in a meaningful way.
And another version of how there may be errors occurring that are going unnoticed, that the medical care system is just working on caring for that patient. You may have heard about the Institute for Healthcare Improvement's trigger tool, which is a way of retrospectively looking through a chart and finding these red flags, these triggers that indicate that there may have been harm, and using that to look more deeply into the case. And when that technique is used systematically on records, often there's a level of patient harm that's found that's like an order of magnitude larger than the individual events that might be reported within the hospital. So part of it is people aren't trying to hide things. They hadn't even necessarily recognized it had happened. A patient took a turn for the worst. They focused on helping that patient rather than forensically examining whether there was an error involved that contributed.
So Paula, let me chime in with a question. It seems to me that half of the problem here is problem identification, that whether it be human nature, the inability to see an error as it occurs, or just the simple definition of what an error is still a looming problem for people to get their heads around. Is that correct?
Oh, yes, and that's why one of my favorite ways of thinking about this is that we're not trying to focus on reporting and classifying and counting errors. The real challenge is that everybody in healthcare has two jobs: doing their work caring for patients and looking at where their systems could be improved so that they're error-proofed, or so that errors don't harm the patients. It's really a matter of changing the culture and supporting the individuals in the system to have the skills they need, and supporting them to recognize where there's an accident waiting to happen, what kind of process, if it hasn't harmed a patient yet, could harm that patient, and continually throughout everyone's work every day, making those changes to make care safer. It's not going to be just about building databases.
So let's try to establish what those quote-unquote vectors of change are in the context of a bureaucratic hospital system where you have administrators, you have chiefs of medicine, there's learning centers with residents and medical students. Where is the impetus coming from, or are these centers more powerful than others in terms of solving or evaluating these problems?
Well, I'll give you an anecdote. In Europe, I'm told, all errors are made by trainees. So you have a really good system there where You know, if you're going to make a mistake, it's an intern. You know, but once you get to be an attending, now you're past that. So that's sort of convenient. I would say that based on my travels, and you know, Tom goes all over the country and talks to medical students. I think there's a tremendous variance between the cultures of institutions. Just one example. In my practice, when I used to hire a new person, I used to tell them, look, if you do your job and you seem friendly and you're nice, I'll pay you a salary. But if you ever see me about to make a mistake and stop me, I'll pay you $50. So the idea that I need help from my error protection system is a novelty in some places. The concept of pipe up, you know, like the crew resource guys have done in the airplane. The idea that in the cockpit you see something horrible, it's unethical for you to be silent and not to raise your hand and say, I need clarification on this, excuse me. And even that simple thing, you know, as Paula says, is one of the difficult hoops we've got to get students and professionals through if we're going to make a safer environment.
I want to address 2 points that came out of that because I think it's very, very interesting. Number one, and Tom, I'm going to throw the question to you, and that's one of regional variation. Perhaps even in the context of the United States, smaller hospitals, larger teaching hospitals, and how that dynamic varies, and potentially even how that can change globally, because clearly this is a global problem, not confined to the United States. And secondly, is speak to the nature of the pecking order, that the chief of medicine does a procedure where he's assisted by an attending, and there's an intern there and a medical student. Will someone speak up in the context of that pecking order? So Tom, let's first talk about geographical variations in your experience, and then look at the hierarchy of medicine and how restrictive that might be.
Well, I think lack of physician engagement in patient safety is one of the critical problems that's holding us back. And I think when you look at, you know, some of the variation in the quality of care, there is a lot of variation regionally. I think one potential explanation is varying levels of physician engagement. You know, physicians are not engaged in patient safety for a variety of reasons. When I was trained in medicine, it really was still in the model of the individual doctor taking care of an individual patient. They lack the focus on systems of care that really help them answer the question that Paula asked, which is, how is my system set up to cause problems? But the organizations that are really doing this well are where the message of physician engagement is coming from the top and engaging the entire physician community. The senior leaders are showing by example how much they care about safety, how they think about safety as a system property, and that brings really the rest of the physician community along. But I think that's probably the number one problem to solve, is how do we get physicians more engaged in improving safety.
Tom, let me interrupt real quickly, because you used a phrase. You talked about patient safety. And I'm curious, what's the difference between patient care, quality care, practicing medicine, and patient safety? It seems like by calling out patient safety, you have a bit of a problem just in the language. Is that perhaps an issue?
There is a little bit of a problem in terms of language. You know, patient safety I see as really the avoidance of harm to patients, not doing things to patients that are harmful. It's a subset of the bigger issue of providing high quality care to physicians or to patients. But I don't think it's nearly as much the terminology that holds physicians back. It's the punitive culture that Michael was talking about. It's the lack of system thinking that Paula was mentioning. You know, I, as a medical student, the only training in working as a team that I received was when a kindly attending pulled me aside and said, "Be nice to the nurses or they will torture you." And that was it. And so, you know, we really, if we're going to deliver care as teams, we need to do a much, much better job of getting all of our physicians to think of teams and systems and much less about the sort of the impact of themselves as an individual.
Well, let's go back. I want to go back to this notion of pecking order. That as a young impressionable medical student who may cite a potential error, unlike the cockpit speak up phenomenon, is there still that hierarchy that suppresses appropriate and timely engagement with respect to errors?
There is clearly a hierarchy in medicine, although one of the nice things that AHRQ has done is to take the crew resource management concepts that Michael was mentioning and turn them into helpful curricula like team steps that give not only junior medical students but also nurses strategies for speaking up against power differentials. But it makes a huge difference when you just sort of see how the senior physicians are behaving, when they really accept feedback and see it as a learning and a patient safety moment. It really spreads like wildfire. When they behave in the opposite way and act disruptively, for example, it really has a dampening effect. But there are tools, practical tools that we can teach that can help people deal with those power differentials.
I think it's extremely essential to see this as a characterological problem. There are people that are simply good bosses. I haven't met many of them, but there are some. And there are people that are horrendously bad bosses. So look around at the business literature and you see that the majority of people do not like their boss. In medicine, we have that same culture that has enabled really people that have very few human skills to be the leaders of teams and to make a model of interacting in a group. And we have been unconscious of it, and we haven't looked at it as a safety hazard before. But I think now, if we were to, in the airline industry and in the Navy running a nuclear submarine, they absolutely know that a bad manager can get us all killed. And so we need to learn some of those lessons and begin to actually address among each other as a teaching goal and as a personal goal for advancement. How well do I interact with the people that I need around me, who are the eyes in the back of my head, that are going to tap me on the shoulder? It could be anyone to tap me on the shoulder and say, that's the wrong syringe.
Let me chime in. I think that those points are absolutely essential. And when you say anyone who can tap me on the shoulder, we often speak of these medical errors in the context of the physician hierarchy. But I'd like to spend a little bit of time talking about other healthcare providers, whether it be a scrub nurse, a circulating nurse, a nurse on a ward, or other people involved in the chain of care, and how safety plays into this context, and are they being embraced as either part of the problem, part of the solution, or both? So I'd be interested in the panel's comment on that.
Well, as Tom had said, it's really about the team, and we've seen some extraordinary work in teams working on infection prevention, where people in environmental services are critical to infection prevention. They're truly having an understanding of which patients need certain types of precautions, being effective in cleaning and understanding the importance of the cleaning for infection prevention. There's some wonderful ideas that have come from transport workers, environmental services. It really teaches you that that there's an awful lot of smart, caring people working at every level in healthcare, and you're simply shooting yourself in the foot if you don't take advantage of all of that frontline input and get all of their contributions to improving patient safety.
And what you see happen, for example, one of the Team Steps tools is called CUS. C-U-S. It stands for stating you're concerned, stating you're uncomfortable, and then saying it's a safety issue. When you train doctors and nurses in using CUS, what you'll see is that all the nurse needs to do is say, Dr. Gallagher, I'm concerned, and then the doctor will say, ha ha ha, you're cussing at me, and they'll laugh and stop and take care of what the problem is. But it requires teaching both the cusser and the cussee. Although at one of our hospitals they use not cuss but cuss, P with a P at the end, because they say if you tell the doctor it's a safety issue and they ignore you, you start to use profanity. But when it works well, it really does work well, and you can avert a number of safety problems with practical tools.
Dr. Gallagher, let me chime in, because I think you've touched on something that sounds to me that is both intellectually and promotionally resonant in terms of managing errors. And this notion of cuss, I think that people are looking for a get out of jail free card almost, to be able to articulate or discuss a medical error or something that puts them at a heightened level of concern. And I'm curious to know, how widespread is this, and is this something along the lines of, let's say, the checklist manifesto, where you have a simple tool that can be executed across institutions? Is this anecdotal, or is this widespread?
No, CUS is one of, I think, 30 or 40 different tools within the TeamSteps toolbox that individuals can use to improve team communication. It's not intended to be a get-out-of-jail-free card. It is intended to give people concrete skills that they can use to raise safety concerns. You know, when the safety movement started, a lot of people thought what we needed was to get away from this shame and blame culture and move to what was called a blame-free culture. Well, everyone knew that wasn't going to work because, you know, there is a mixture of individual and system accountability for care that's not gone well. One of the other important changes we're seeing is that people are moving towards what we would call a just culture, systems and mechanisms to hold healthcare workers accountable for their individual contribution while recognizing the important role that systems play. So I think it's a disservice if people feel like this is somehow a way for people not to be accountable for their actions.
And John, if I could also add, I have to admit you hit one of my hot buttons. I sometimes find it a little frustrating when people think of the checklist as, why don't they just use that checklist? Mm-hmm. It's actually extraordinarily complex, and it's about, as Tom says, it's about having people communicate better, work better as teams. If they're not using the checklist, it's very rarely a simple issue. So similarly, I find it frustrating when sometimes there's a sort of dismissive, why don't they just wash their hands? Often it's very complex, the number of times people have to go in and out of the room and what they have with them or don't have with them. And so another one of the tricks is making it, in terms of processes, trying to make it easy to do the right thing and hard to do the wrong thing. But as Tom's saying, it's also, and Michael's saying, it's also always about the culture and whether you're supporting that effective teamwork and the ability to keep safety a priority for everyone in the organization.
Very interesting observation that you often have that sort of knee-jerk reaction to just wash your hands. One of the areas I want to discuss, and this is something that's coming in through social media and Twitter, is a question that typifies these questions by Rory Brill. And Rory asks, how do you envision technology playing a role in solving these problems? And we talked a little bit earlier about that, and I think, Michael, you had some insights about the pros and cons of technology emerging as part of the solution and perhaps something else.
Well, in a way, Tom was talking about a organizational technology by having a mnemonic that helps communication work better. Paula mentioned checklists are technology that could be potentially used. These are really low-tech devices, but we can move up to technology all the way to MRIs and artificial intelligence. Something I've said often is that if you would ask me the #1 technology that's underused that could help reduce patient safety events and harm and improve efficiency to do everything that we want in healthcare, I would say it's the telephone. The one technology we don't use enough is the phone call between one doctor and a nurse and a radiologist and a pharmacist and a lab person, because we do not communicate enough among ourselves. I just say that in a blanket global generalization. I'm prepared to fight anybody over that. But in addition, we tended, I mean, the first half of this discussion, we were sort of circling around a magic fantasy that if only something, there would be no errors. And I think we've got to be real careful not to fall into the trap of saying, why, if only people spoke up, if only we had electronic health records, if only everyone got an X-ray when they had a cough, then there'd be no mistakes. That is dangerous nonsense. And in my own domain, one of the things I need to point out is that when fetal monitors got installed, or CAT scanners, or even radiographs. 100 years ago, we began to say, oh, I have this technology. Think how much a better doctor I'm going to be now with this technology. And of course, it worked that way. Of course it did. There was a Harry Potter magic wand aspect to some of these devices and gizmos. But if you talk to the FDA, they have list upon lists of device failures and things that went wrong with the local computer or the lab or the x-ray or the you name it. And so all of these are two-edged technologies, and we need to implement them. Yeah, I am absolutely in favor of using computer assistants to help me remember things. My gosh, I make lists to remember things. But let's also remember that I can have a miskey event on my keyboard and remember something totally wrong. So there is nothing in the world that doesn't have a positive and negative effect.
I want to chime in there a little bit because I'm interested in learnings from other industries, and this is something that we've been getting on Twitter and Facebook. The question is simply, what are their learnings from other industries? And we talk about the checklist in the cockpit, so to speak. And what are some of the pitfalls about applying assembly line safety techniques to the complex human dynamic of healthcare? And maybe Paula, you can start us on that.
Well, actually, I was thinking as you're saying that one of the fascinating things I heard recently about the use of the checklist when it was first introduced in airline safety is that they found that the pilot doing the checklist for him or herself didn't actually improve safety. What contributed to safety was the cross-check between the pilot and someone else in the cockpit that actually confirmed that those events had happened. So that it's often about understanding what contributes to error, how do humans interact with their environment, and often it comes back to teamwork that makes the difference.
So I'm compelled to use the word redundancy in terms of evaluating. It's not just the individual and enhancing their ability to use a checklist, but it's the duplicity or redundancy that perhaps may play a role?
Well, apparently it turned out in some way, and I'm sure there are greater experts in airline safety who would put this more precisely, but that a pilot is completely capable of making an error and thinking that the flaps were in that position and confirming that they were when in fact they weren't. So it's the study of how humans interact with their environment and your testing process to see what actually contributes to safety. So I also think one of the things we've really learned from other industries is the importance of every single individual. Every individual is an expert in his or her own process. They're the ones that the transport worker can see the problem with the wheelchair that people might not think is significant, but nobody else knows about. So again, I think it's really valuable to learn from other sectors that this is something that's everybody's job, that the leadership is demonstrating the commitment to safety and supporting the process changes and putting resource towards it, but that we really need to have everyone looking at the processes of patient care and making the myriads of changes that are going to contribute to patient safety.
That's very interesting, especially in the context of sort of the methodological considerations in the management of patients that is somehow combined with the psychology and the human nature of social engagement in care. So that's very interesting. I challenge the group, are there any other areas outside of medicine that have been leading discovery or innovation around the concept of safety?
A lot of leading organizations in the Seattle area, like Virginia Mason and others, have been using lean methodologies and Six Sigma approaches to try to improve safety. You know, you definitely get some pushback from frontline clinicians when you bring in concepts from other industries, but I think it more often reflects physicians' fears of losing control and, again, an inability to think in terms of systems and their role in systems than it does really their sort of lack of acceptance of what we can learn from other industries. It's really a culture shift for physicians to sort of realize that they're not the only ones involved, they're not the sole captain of the ship, and getting them engaged in that way sort of opens them up to learning some of these lessons from outside of healthcare.
Yeah, you know, there are lots of organizations that do way better in terms of systematic approach to safety. A couple that you could mention would be a nuclear power industry, SWAT teams, you know, special forces warfare experts, and there's a lot of simple manufacturing organizations. And I don't imagine that the Toyota factory has a lot of people falling into the, you know, the engine thing very often. And there's a mythology. It's not an entire falsehood. It isn't dead flat false, but there's a terrible disproportionate mythology about, I don't want to do the cookbook thing. The doctors still have a conceit that says, I don't use checklists, you see, because every patient is individual. That's really not true. That's more false than true. Almost every patient has DNA, one head, couple of eyes, some arms, legs, similar number of hearts and livers. People are much more alike than different. And so, yeah, at the refinement level, we need to have a human expert there that can modulate the checklist. But we have not learned to have standardization in some of the routinizable parts of medical care to the level that some much safer organizations already have learned.
So put on, I want the panel to put on their white coats now and think about clinical practice, because from the nature of the physical exam as a very systematic approach and a checklist kind of phenomenon as taught in medical school, even to the differential diagnosis, it is in fact a checklist phenomenon. Why is there pushback? What's the rub with clinicians in that context?
We're not good at it. I have my own personal, this is maybe maybe overly personal. If you give me a checklist, you give me the opportunity to fail, because I'm not really good at following lists, and I'm not so organized, and I forget stuff. And so now you've given me the opportunity to do something wrong, and you can measure it. Paul is going to be standing right there saying, wait a minute, you skipped step 3. What's wrong with you, you idiot? And now I'm going to feel bad and be embarrassed and ashamed, and I'm no longer the chief of medicine. I'm just an idiot who can't follow a list. And so I have an allergy to following orders, because I am very used to thinking everything I do is just perfect.
Doesn't the clinical exam and the differential diagnosis follow the form of a checklist that I could be ridiculed if I did not consider pheochromocytoma as a workup in the context of hypertension?
Yeah, well, I mean, you're talking reality. I'm talking psychology. My goal as the chief of medicine is to remember that in my brain and not have to rely on a paper, because, see, I remember everything. You notice in my perfect mastery of my craft, I don't even have to look at textbooks anymore. You know, that's embarrassing. I don't look things up. I know it. I know everything. Didn't you? What's wrong with you? Don't you get me as a doctor?
Paula, you wanted to comment. I think we chopped you off there a little bit. Please join in.
Oh, I was just going to emphasize that what Tom and Michael are also saying is that, you know, hopefully physicians will be able to recognize that there is more complexity, I think it's fair to say, in medicine than in some of the high reliability sectors we talk about. But that's why physicians are always going to be crucial, and their clinical skills are never going to be replaced. These other things that we're talking about are simply tools that help error-proof the process. So I think we continue to be really hopeful that there's a recognition that we wouldn't have medicine without physicians, but these things are tools to help them from harming a patient, which is the other tragedy. The second victim is not only the patient, but the clinician who didn't go into medicine to harm patients. So
great. Let me, Tom, a question for you, and this is something that's coming from Twitter. The question is, do healthcare workers perhaps fear that over-dependence on systems and lists somehow dehumanizes the practice of medicine? And is that some kind of an emergent fear or even a subconscious driver?
Well, you know, we certainly are seeing, I'm headed off to clinic in about 15 minutes from now. And so, you know, when I'm in clinic, for the last year, there's a computer terminal in the exam room, and I'm typing notes into that computer terminal as I'm seeing the patient. And so there's sort of a new piece of technology that has the potential to get between me and the patient. With computerized physician order entry, rather than walking down the hall and grabbing the nurse, I can just type in a little note to them. And we lack that interpersonal interaction where we can really confirm that we're understanding one another and avoid errors. So I do think there's a bit of a concern about depersonalization, but I think we're missing the point just a little bit when, I don't want this to sound like we're physician bashing. A lot of my research has been in the area of disclosure of errors to patients and how physicians approach that. And one of the reasons I think we've had some success is that we've really tried to understand where are physicians, what are the barriers and challenges that they experience. And so I think to really succeed at engaging physicians in patient safety, rather than coming at them with a checklist or a methodology and sort of saying, why aren't you doing this? We really need to step back and understand much more their lived experiences, the barriers that they see, and I think it will be easier to get them engaged in that way.
Tom, let me chime in and piggyback on that. Is there a bit, we talk about a gender gap. Are there different different states of level of training, age, techno-savvy, not so techno-savvy, groups of physicians, nurses, or caregivers where these differences seem to be exaggerated? And can we talk about caregivers as a monolithic group? I think that's problematic.
I do think that some physicians, which is the group I'm most familiar with, are more technologically savvy than others, but I think the real difference is much more kind of a willingness to engage with new approaches to care delivery. Even the most senior physicians who aren't used to using computers, if they're willing to give it a try and they see the benefit to patients, they're off to the races, as opposed to the young doctor who sort of feels like, well, they're not willing to try out these new technologies. So I don't think it's exactly an age gap per se. I think it's more a willingness to step back, self-reflect, and look for opportunities for improvement and to embrace those that really work.
Interesting. Any more comments from the group about that in terms of looking at behavioral changes? And again, we talked more about psychology today than we did in implementing sort of rigid guidelines. But how does that work across? We know that patient types are different, that someone who lives in Massachusetts might be quite different than someone who lives in the South. Are there regional variations or cultural variations in the context of care that might be relevant here in some way?
Sure. There's not only regional, but in your waiting room there are variations. When I did a lot of work in the ethics of end-of-life counseling, we used to have sort of a colloquial understanding that there was one sort of an Emily Dickinson patient who was very gentle and very accepting and interactive, wanted to hear things in a gentle tone, and have facts cushioned. And then there was the Dylan Thomas kind of patient that just wanted to get slammed in the head with the truth. You don't be brutal here. Come on, let me have it. Come on, let's go. And no doctor or nurse or minister, for that matter, will be able to interact successfully with every personality type in the world. But we do know that you have a repertory of people that you can successfully communicate with, emotional stuff. And in the, if you have a southern doctor in the south, a western doctor in the west, and an urban doctor in the herb, then there may be, we haven't even begun to talk about ethnic and cultural differences or language differences, but this is just another variance on the fact that I may not be the most suitable communicator for you in your current psychology, configuration, language, and culture. Maybe the person at the other end of the table might be a better interpreter for us, and we ought to maybe use them. So this is an area that the cultural competence people have been looking at. with mixed success, that I think deserves a lot more attention from a patient safety standpoint, because again, as Com pointed out, the idea that one doctor as the captain of the ship that does everything, is responsible, accountable for everything, and is the chief communicator of everything, that we need to be more flexible than that. I mean, that's not a very good Darwinian system.
And John, if I could just take off on that point and emphasize, as Michael says, it adds another layer of complexity in healthcare and another opportunity for things to go wrong, the differences among patients and the fact that it involves communications between the clinicians and patients. It's also a huge source of learning. I mean, we have this great opportunity in healthcare that, you know, it's not just cars going down the line where we have to figure out for ourselves what's not working. We can talk to the patients and their families and say, what have you seen that's happened where that's an accident about to happen? Where do you see that we have potential safety problems that we need to address? So that there's really this huge resource that's just tremendously valuable in healthcare to engage patients and families in the work.
So, Paula, I want to interrupt you right there because I think there's an interesting element that, and we don't have much time, but I want to talk about the role of the patient and the caregiver in medical errors, in drug-drug interactions, in a variety of issues that are outside the realm of the physician or caregiver area, so to speak. How does that play in this area of error overall?
Well, first, I would say it's not that the caregiver is out of the picture. They might not be in the home in the moment, but clearly effective patient teachings, and so that the patient and the family know how to care for themselves safely and effectively when they are at home is a key challenge in safety. And again, that's one where we don't have to solve it ourselves. There's a tremendous learning opportunity by talking to patients and families and saying, you know, another time it's a challenge of, you talk about the pecking order. The pecking order is always the patient doesn't want to cause their clinician any trouble. They don't want to be any trouble. But it's really important that we make it comfortable for them to speak up and say, here's what I see going wrong, here's what you haven't heard, here's what I still don't understand, both for their own care, although I never feel that the burden should be on the patient. The burden is always on the system to make care safe for the patient, but they're a tremendous resource, and there's a great deal more we can do to keep learning from patients and families.
Terrific. Thank you. Michael, I want to chime in with one other question that we spoke to earlier, and that's the notion of competing mandates. That within the hospital environment, there's hospital administrators, there's clinicians, there's patients, there's cost factors. And it seems to me that this is a challenge that is being pulled in many, many directions. And I'm curious how that plays into the inherent complexity of the system and the problem to be solved.
Yeah, I guess if we were going to talk about complex organizations, you almost can't find something more complicated than a hospital today. I would never want to be a hospital administrator. And only talking about hospitals now, because I think we need to be a little careful at segregating the safety problems of different institutions. But just talking about hospitals, where we have the biggest handle on the worst accidents. If there were, I'm proposing a thought problem here. You know, suppose there were some technology that your administrator, a salesman, walks in and says, "I have technology that will eliminate all errors in the pharmacy, and you'll never have another error of a drug, and this will simply cost you all of the money that you would spend on cancer treatment for the next 10 years." Now, you know, that's a burlesque of the problem, but it isn't totally unfaithful to the issue. There's a triage problem here. We know that there is a baseline level of injuries, accidents, adverse events. I don't know how many are avoidable. No one knows the avoidable quotient, but it's not zero. And what that means is we need to have also a safety net system in place that says that when that administrator makes their decision, well, I guess we're going to settle for 10% pharmacy errors this year because that's all I can afford to reduce. Then someone has to be there to be able to manage and mitigate and compensate for the inevitable injuries that have to be the accompaniment of running this complex, dangerous system that every once in a while I don't care how hard I was trying. I'm going to do something I'm really sorry for. And we haven't talked, and we don't have time to really go into how to remedy the system of, well, all right, now we have an error. We're going to look retrospectively, figure out how to not have it again. But now I got the patient in front of me with the injury. What do we do now? And currently, I think a lot of us, the hospital administrator, is stuck with the problem that maybe it's best to pretend it didn't happen and cover it up and have a lot of insurance, because I don't know what else we have. And that is another whole topic.
Indeed it is, but I think that layering the inherent complexity of the system with human nature and psychology is indeed quite difficult. I want to begin to wrap things up, but I want to end with one particular question that comes in from Facebook from Julian Gonsalves. And Julian is a medical student, and his perspective is obviously one of prospective, what's life like in the future? And he asks, and Thomas, I'm going to flip this over to you, what should I look out for to ensure that I am not guilty of so many of those mistakes that I've read about? So what's some advice for the future doctors who are going to be confronted with this significant problem as they move to practice?
I think, you know, even though there's an enormous amount of progress yet to be made in patient safety, I think I've never been more excited about the potential. I think medical students are entering the career at an incredibly exciting time around quality and safety. And the advice I give to medical students is first and foremost to understand the importance of transparency. I think, you know, medical students are human just like the rest of us. The normal instinct we all have when something has gone wrong is to keep it to ourselves. And I think the most important thing medical students can do is to learn the opposite reflex, which is when I think something might have gone wrong, I'm going to talk with somebody about it. And that's really the first step in a cascade of understanding the problem and preventing recurrences.
Do you use CUS in your or a similar acronym?
Oh, yes. That's a part of, you know, the medical students go through that. We're doing more and more interprofessional team training. So medical students working with nursing and pharmacy and social work students all together as teams. So, you know, I think that the transparency piece is critical, and then starting to think about themselves as a member of a team is the second critical thing that medical students can do to avoid making errors. But it's a terribly exciting time. It's a great opportunity for students and for the profession as a whole.
Well, I want to end on that note, because I think that the promise of tomorrow, given increased collaborative efforts, the promise of technology, and the engagement of a team like you, certainly bodes well for the future. So I'd like to leave on that optimistic note. I want to thank all of our team members who provided their time today. Our panel discussion was very, very engaging and could go on, I'm sure, for many, many hours. But also I want to thank the TEDMED community who reached out to us today on Facebook and on Twitter. These are important elements of our conversation to move beyond our panel discussion to make this comprehensive dialogue something that we can build on and help seek out solutions. So while this is the end of our particular session today, it is by far the end of our discussion. So I challenge everyone to reach out on Twitter, onto Facebook, onto the TEDMED website, to speak to us, to tell us your questions, your comments, engage us in ways that, that push the dialogue forward. Additionally, I want to thank the Robert Wood Johnson Foundation for sponsoring the Great Challenges program. And I'll leave you with one simple thought, that great challenges demand great thinking. Thank you so much for your participation.